Top Med Talk.
Nick Majerison here, welcome to Top Med Talk. This piece is in 4 parts, and this is the last of them. It's called the Perioperative Cognition Workshop, and it took place at the Australian and New Zealand College of Anaesthetists earlier this year. The other parts to this piece are available on topmedtalk.com if you check in the show notes for this podcast.
So we're going to do a bit of scoring in a moment, just to give you a bit of background about the mini-cog. So this is a very quick tool. We'll talk about the sensitivity and specificity in a moment. You can see that there are a number of versions. So the patient would be asked to repeat the 3 words. They would be said 1 second apart, and you continue repeating them until the patient can repeat the 3 of them. And then they will later, when you've done the next task, you would ask for them to delay the delayed recall of those 3 words. Now, the clock drawing is a really interesting thing, and we're going to focus a bit on that today with our scoring. There's a number of different versions. There's a version here in the mini-cog, there's a version in the Montreal Cognitive Assessment, the MOCA, which David will go through, and then there is a full neuropsychological assessment for a clock drawing task, which involves a much more detailed scoring algorithm. So today we're going to talk about the 2 versions that are quick, easy to administer, and have very simple scoring. Now, when I say simple scoring, it still actually is not as straightforward as you might think. So the clock drawing for the MOCA is a score of 0 if the patient has any errors, and 2 if the patient has drawn a normal clock. It starts with a circle, which is different to the MOCA and to a full neuropsych. A proper assessment that a geriatrician might do would actually, or a neuropsychologist, would require the patient to draw the circle. But for the moment, we're going to look at the MOCA, the mini-cog clock, and I'll just put this in there to...
So this is one I drew.
I'll just put this in there just to highlight a couple of things that are important when talking about scoring of the mini-cog clock. Now, you and I are looking at those hands and saying that they say 5 to 2. Does everyone agree with that? Okay, so if you are doing the MOCA clock, or if you are doing a neuropsychologist clock, then the length of the hands is important. So that would be 5 to 2. If you're doing the mini-cog clock, the instructions are that you need to draw a clock with all the numbers, and you need to put the hands at 10 past 11. Now, for the mini-cog, the length of the hands doesn't matter. So, in fact, you would be able to say that this, in fact, was correct at 10 past 11. I'm getting confused. Can't remember myself. So you could be correct in saying that this actually is 10 past 11 instead of 5 to 2. So I'll leave that with you. Now we're going to...
First poll now.
And we're going to show you, I'm going to show you a clock, and I want you to give it a score of either 0 or 2, depending on whether it is a correct clock or an incorrect clock. Remembering the hands need to be 10 past 11.
And this is clock 1.
Clock 1.
Clock 1 mini clock.
Okay.
So just score that first
one. Score that.
0 or 2?
0 or 2.
That's great. All right. Hands up who thought it was 0.
Woo-hoo.
Hands up who thought it was a perfect clock. Okay, well done. Having seen the answer.
Okay, so not surprisingly, this is a 0. So the positive thing about this is that all of the numbers are actually correct and in the correct quadrant. So that if we were scoring it differently, they would have actually got some points. But for mini-cog, they get nothing.
And the other thing about the mini-cog is they get a circle already.
Yes, they do. Whereas the circle is scored in the MOCA clock and also in a neuropsych assessment.
So that just summarises what we were saying, and I think Liz explained it very well. So that's the mini-cog. So it's quite simple to administer. It only takes a few minutes.
Yeah, it's very quick. And then after the clock drawing, you would ask the patient to recite the 3 words that you had asked them to speak back to you at the beginning.
And how would you score it?
So the clock is 2 points if it's a normal clock and 0 points otherwise, and then the initial speaking of the 3 words is not counted, but it's a 0, 1, 2 or 3 for the delayed recall of the words. So maximum score is 5.
So you get them to learn and retain the words, and then you assess the delayed recall. So then we have the MOCA, or the Montreal Cognitive Assessment. What has been the most significant and disappointing application of the Montreal Cognitive Assessment in the last 3 years? President Trump was confirmed to be cognitively intact by passing the MOCA. Respectfully, I say this. So it is a screening test, like other screening tests, but it is, as you can see from the sensitivity and specificity, it is better at detecting low grades of memory impairment. So it can detect, and it was actually validated and developed in about 1996 in Montreal, strangely enough, to assess to detect early forms of mental cognitive impairment and mild cognitive impairment in particular. It assesses a number of domains, so you can see the domains there, visuospatial, executive domains, simple naming of animals which are not commonly seen in Canada. There's a memory test where there are 5 words, and there's a first trial and a retrial for a delayed recall assessment. There's attention where you have to repeat 5 numbers in a forward direction, which are said to you, and then the second test is repeating 3 numbers said to you in a backwards direction. There's a motor synchronisation coordination test which also focuses on attention, where you read a string of letters and ask the patient to tap whenever you say the letter A. And then there's serial 7s, which we've heard about, but only going down, I think, 5 layers in the serial 7s. There's a complex language sentence to try and understand, which is, where is it there? I only know that John is the one to help today. And you've got to repeat that. And then there's another one about cats and dogs. There's an abstractive concept. So what are the similarities between a train and a bicycle? Bit easy. Okay, so what are the similarities between a watch and a ruler? I'll leave you to dwell on that one. Bam, -2 points.
There's only one correct response.
Yes. So you've got to get one. You get 1 point for that. And then there's a delayed recall of words. So of 5 words. So that you learnt earlier. And there's an orientation test as well. So it's a lot more complex. It's still scored out of 30. And if you get less than 26, some would say less than 24, then it suggests you do have some cognitive impairment. The other good thing about this is it is available in a number of languages, almost 50 languages it's available for. So they've transformed some of these things. So obviously if it was in Egyptian, a camel would be a common object, so you would probably have a platypus. Maybe. I don't know, I haven't seen the Egyptian version, but that's the idea, that it is context sensitive to the culture as well.
It's also available in 3 versions. So in terms of doing serial assessments, you're trying to avoid practice effects.
So up here is the area where the MOCA clock exists, and it doesn't have a circle. So you would say to your patient, I want you to draw the face of a clock, put in all the numbers, and set the hands to 10 past 11. And then you would score it based on contour. So the quality of the circle is important. The numbers, that they're in the right place, and that the 2 hands are pivot on the centre, close to the centre of the clock, and that you can distinguish between the lengths of the hands, and obviously that they're pointing in the right place. And a point is assigned for each of these. So the best you can do is score 3, the worst you can do is score 0, and obviously you can score 0, 1, 2 and 3. So we're going to do this again with app. Yep.
Just for the MOCA clock, the numbers can be inside the circle or outside the circle.
Or even on the circle. So here's an example. So question 4 with your app. We'll try that. Is that going to work?
Working?
It's working. Oh, good. Okay. So fire away if you've got the app open.
0, 1, 2 or 3.
Yep. So 0, just press a button and save. Okay, so there's the answer. So most people think this is a 3. Small group of tough markers thinking it's a 2. That's great. Okay, so it is a 3 based on the criteria. It is a circle. All the clock numbers are present in the right quadrants, and the 2 hands as we described. So that's a 3.
But the other thing about this is that there is some discrepancy with inter-rater reliability for the scoring of the clock. And if you were actually using this as a screening tool in your environment, you would undergo appropriate training, or your staff would undergo appropriate training, so that you are consistently scoring.
And what really concerns me is with the answer up and having been stated that it's a 3, someone rated a 0 whilst we were talking. Okay, back to the presentation, please. So that just summarises our scoring for that one. So this is the next one. This is question 5, clock 5. So again, you've got 3 points to answer. The contour of the circle, there's a clue there, the numbers, and in the right quadrants, and the hands being present and different lengths. Okay, so we'll go to the scoring now. Okay, it's a good spread. And there is some, you've got to get used to these things. You can't just do it for the first time. You've got to get used to scoring them, I think. And there are, but it is quite a sensitive tool. So we'll go. So the prevailing vote is for 1 point. We'll go to the presentation again now. And indeed, we in our wisdom thought it was 1, 2. We gave 1 for all the numbers being present, but everything else was rubbish. So that was the cock drawing that. Okay, last clock. So here we go. 3 points max for this one. See how you go.
Bearing in mind, these clocks are all examples from our patients.
He got 3, apparently. They reported him at getting 30 out of 30 for the mocker. Okay, so we'll take the scoring now. Majority scored 1, and we'll go back, and a couple scored 0, and that's not actually unfair, actually. So going to our back to the presentation. So we gave 1 because we thought the circle was all right, but it's not a great circle. So
they could easily have scored a 0.
It was a good day so far. So that's how
we're being generous.
So you can see already that the mocker does have a bit more sensitivity because it's got a bit more discrimination in the different things. So we'll now move on to a different type of test.
Okay. So one of the problems with neuropsychological assessment and screening tools is that you have to have the patient in front of you. And obviously that's not always an option in the preoperative environment. So the TICS is the telephone interview for cognitive status. It's actually a score out of 50. It's quite a long questionnaire. It takes about 15 minutes on the phone, but you don't need to be an anaesthetist or a geriatrician to administer the tool. So you can, nurses could be trained to do this, our research assistants do this over the phone. And the scoring is that, but it's a score between 19 and 38 is possible MCI. So it's a screening tool again. You need to undertake a full neuropsychological assessment or a geriatrician, 5 minutes. Oh, goodness. A geriatrician assessment or referral to a geriatrician for a full neuropsych assessment if you think the patient is at risk. But in terms of identifying patients who might be at risk, who need to be managed differently, this is a good screening tool that can be done, obviously, over the phone. Excuse me. So just looking at the screening test we've talked about this morning, we just wanted to present to you the sensitivity and specificity. The important thing to acknowledge here is that the mini-mental and the mocker, those sensitivities and specificities refer to how well they identify mild cognitive impairment. The mini-cog and the TICS are screening tools for dementia rather than mild cognitive impairment. So you're not getting that subtlety in those screening tools. And now we're going to talk a bit more about the 4AT and briefly cover the 3D CAM in the 4 minutes that we have left. So now we've talked about hypoactive delirium, but we haven't really talked about what it is and hyperactive delirium. So I won't go into a lot of detail, but just to remind you that whilst we all think we know delirium and we'll be able to stand at the end of the bed and identify it, in fact you won't. You'll be able to identify agitated delirium, but you won't be able to identify hypoactive delirium unless you do a proper assessment. It's really important. And hypoactive delirium is much more common than hyperactive delirium. So it's the one that we notice much more significantly in our patients. Similarly, there's been a lot of people say that you only need to assess once, perhaps on day 3, or you only need to assess in the morning or the evening, the sundowning effect. What we found in our patients is that both for non-cardiac and cardiac surgery, it didn't really matter. We didn't see a specific morning or afternoon right out to day 5 that we could say this is the time when we're going to see delirium. So trying to assess the fluctuating course, we need to be doing twice daily assessments. So the 4AT is what's currently used at St Vincent's, and the idea is that it can be implemented by nurses at pre-admission clinic. It's a screening tool. It screens for at risk of cognitive impairment or delirium. It's principally used for patients who might be at risk of delirium. It's quite different to something like the 3D CAM, which we've just put up there. Obviously, it's too busy for you to read. The 3D CAM requires a lot of training. It requires a much greater level of investment from the staff who are administering it, and it actually is a diagnostic tool. So it's quite a different thing. It's still quite quick, but it does require significant training. So the 4AT is the four A's: alertness, AMT4, so that's an orientation question, attention, and acute change or fluctuating course. The really important thing about this is that for delirium, you need to know the answer to number 4. What we're finding in our environment in the hospital is that, in fact, this is done by the staff at pre-admission or admitting the patient, and it's not usually done completely. So it's a difficult situation where we're not getting the results that we need. We're not actually screening the patients appropriately, and we don't have a referral pathway at this point in time anyway. But it is a good screening tool, and if it was implemented properly with appropriate pathways for a further investigation for diagnosis, if the patient's identified at risk, if it's appropriately used. So I think you're going to do the summary slide.
Yes. So just in summary, we've been through the new recommended nomenclature. We've tried to help clarify that whilst they do overlap, delirium is different to delayed neurocognitive recovery and what people used to call early POCD. The 3 risk factors are clearly there. Screening needs to be applied correctly, but when it is done, it helps to identify at-risk intervals. We've got some simple screening tools available, which are pretty quick to administer. And the bottom line is that this is about whilst we've been talking about assessment and so forth, who's doing it, who you're communicating with, it's a team approach, very much so. And one of the things about perioperative medicine is, a close relationship with geriatricians and physicians, and of course your surgeons in the hospital is very important when you're dealing with these challenged patients. So thank you for your attention. We do have time for a couple of questions. We've had a couple come in from the app. I'll give you that. First one was just someone who wasn't paying close attention was asking what test did Donald Trump do, and that was the mocker. The second one is a great question. What's the future of drawing a clock as digital clocks take over? Yeah. And,
Well, it is a problem. It may be that in 30 or 40 years we can't use it as a screening tool. But as you can see from the clocks that we presented from our patients, it's a really sensitive tool. Those patients drew those clocks after actually completing a full neuropsychological assessment without any problems. So it's actually identifying some really subtle impairments, and at this point in time, it's a really good tool. And
the clock seems to be a useful change tool. So you can get a good baseline clock and then notice that in the DNCR phase, it's actually a wonky clock, and then they recover back to being a good clock, or actually deteriorates. Toby?
On the clocks, it's a little subjective sometimes on the assessment. Mm-hmm. Is there an app that you can just photograph and upload?
So there is a digital version available that scores as you do the clock, but I haven't used it.
Yeah, I'm sure there is an app. There's an app for everything.
Yeah.
But the clock is becoming very popularised. But I hope we sort of convey to you that it actually does require some discrimination, and also change over time is a useful thing. Any other questions? I haven't got any others coming in on the app at the moment. Oh, Toby, again.
So at St Leeds, if you're doing a 418 for assessment, and I guess there's many here, if someone scores low, do they have capacity to consent to the operation?
So I'm not
go to the next slide.
Well, we haven't got time, but I was going to. Seriously, the next thing was gaining consent. Thank you for that. And that's a real issue. And we do need to consider that it needs to be voluntary, it needs to be competent, it needs to be documented. And probably the important thing is that a third to a half of our patients older patients coming for elective surgery, particularly if they've got vascular disease or cardiac disease, have some form of undiagnosed cognitive impairment, mild cognitive impairment.
That you wouldn't, as the clinician interviewing the patient, you would not be aware of that subtle impairment.
So you all know about the consenting process, but just to be clear, the patient or carer giving permission for procedure needs to be given sufficient opportunity to consider. So it's not on the trolley about to be wheeled into theatre is not an opportunity to consider. And then they need to have a clear and understandable explanation. So you need to make sure that that patient who's got some cognitive impairment, if they're the one who are consenting, and they may be legally able to consent because they're not considered incompetent, they've got a clear understanding of what's going on, and you've given them an understandable thing. We're going to do a hemicolectomy on you, is that okay? And then the risks and the benefits, so they can balance the two up. So I won't go into the rest of the consent thing now, but I think this is an emerging field where we actually are, and I know I am, and I'm sure many of you are, getting questions now from older patients. Am I at risk? What's going to happen? And the answer is mostly reassuring, but 10%, around about 10% on current data, still at 3 months will have some form of cognitive impairment. It shouldn't interfere with their function. And we will learn more now that we're applying the new diagnostic tool because it'll be clinically relevant. And if they've had delirium in the past, that's a real concern, and they need a lot of reassurance and engagement with the physician team to help care for them. Yes?
That 10% being disclosure, is that in all colours in an age group?
Yes. So if you've got pre-existing cognitive impairment, you are at a higher risk of further cognitive decline. There's that debate about are you on a trajectory or is this actually amplifying it? Certainly for dementia, it seems to be amplifying it if you have delirium, and probably we'll find that it's unmasking some and amplifying others. But I'd defer to the geriatricians to answer about competency for consent. But if you've got any concerns, clearly, and if you've got an existing diagnosis from a memory clinic, then you would obviously need the partner involved. You can usually explore whether they actually understand what's going on. I mean, the ability of even demented people to confabulate is quite high, but once you start getting into an interrogation, question-answer type of thing, you soon find out that they may have a gap. Yeah.
No, I was just going to say it's one of the problems with a lot of POCD research is that we've only looked at one point in time preoperatively, so we don't know what the trajectory is. So in terms of delayed neurocognitive recovery or neurocognitive disorders, there's no evidence that regional has any different impact compared to general anaesthetic. Yeah.
But we're still looking. Yes.
Okay. I think
one last one at the back.
Oh, okay. One last question.
So the question is, I understand, is the long-term impact of all those little insults that they get during their recovery. That was part of the reason for the delayed neurocognitive recovery period, that, up to 30 days you'd expect them to have got through most of those. But these are clinical diagnoses now, so you can take into account their context. Yeah. So if someone's still got a suppurating ulcer and they're still limping around, that's a different thing to someone who is actually healed but not cognitively perfect. Years and years, so after 12 months we're not saying it's related. If it's a new diagnosis, it's not related to the surgery, it's related to whatever else is going on in their lives. Yeah.
Thank you all very much.
Thank you very much.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.